The challenges involved and what's happening in the management of resistant hypertension. Well, this is the alarming state of hypertension in India, and the NFHS and the ICMR data telling you that maybe we have about nearly 300 million hypertensives. So if you want me to define resistant hypertension, the conventional definition has been there from the JNC days, 2003 days. Nothing much has happened in the definition, which says that a hypertensive patient on 3 drugs, one of them being a diuretic, still have above the goal blood pressure. The goal may differ. Earlier it was JNC time, it was 140/90. It seems now at least it may be 130/80. I mean, there is no consensus that the guidelines differ on that. Well, all agents should be administered at maximum tolerated dose, and the adherence has to be entrusted. Well, the publication, if you look at the resistant hypertension publication, you could see alarmingly increasing, understandably so. This is what I was saying, the prevalence may change with the definition of your goal. But then on an average, it is about 10 to 15%. Whenever you have, and it is not uncommon that you have in your clinical practice a patient with uncontrolled blood pressure despite he being on all the 3 drugs that we have said, ACE/ARB, CCB, and a diuretic. So you have to see whether this is a true resistant hypertension, because as you could see here, now a sizable amount of people have what you call the pseudo-resistant hypertension, and these are the causes of, so exclude pseudo-resistant before you brand somebody as true resistant hypertension, and the reasons being poor adherence, which we know. Almost 50% of our patients given antihypertensive drugs unfortunately are not adherent. Rule out white hot hypertension. Measurement of the blood pressure is absolutely important, and possibly what is more vexing for us clinicians is our own inertia in up titrating the doses. Adherence, again, even this was one of the data which showed this was actually a renal denervation program, even in those who were meticulously followed. In renal denervation patients are very rigorously, even in them you could see about 50% adherence is only there. Of course, how can you improve the adherence? Possibly these are things that every one of you know: fixed dose combination, once daily combinations, low cost, generic drugs, of course, educating patients. Clinical inertia, again, is something which I don't need to cement it in with you, because that is something which we have to improve on. See that our patient with an elevated blood pressure, despite the 3 drugs, are not taking any of these drugs, which can theoretically increase the blood pressure. A couple of years, the American Heart Association gives you a 120-page document on how to measure blood pressure. So I don't need to tell you about the importance of measuring blood pressure. This is something which, again, which is rather common. At least 30% of your patients who has uncontrolled blood pressure, despite these 3 drugs, may have a white coat hypertension, and this remains. Now, this white coat hypertension may be persistent. That is something which you have to understand. So, and this problem can be definitely ruled out by doing a ambulatory blood pressure monitoring. So before you brand somebody having a resistant hypertension, exclude white coat effect by doing an ABPM, and then see that the medications are adhered to. I don't need to, again, I have no intentions to tell you about ABPM, and it's important. Way back in 2007, ABPM was considered as a class 1 indication by the ECCON, but then basically because of the logistic problem, we are still hesitant to do ABPM. But ABPM is a must in resistant patients with resistant hypertension. The general patient characteristics of a guy with a persistently elevated blood pressure are these: older age, multiple comorbidities, obesity. You're aware of the term of hypertension. I mean, those with the target organ damages, diabetics, of course. So this is the algorithm for evaluation of the resistant hypertension. Confirm this is true resistant by excluding pseudo-resistance. Assess for any, we should know that about 5 to 6% of your persistently elevated hypertensive may have a secondary cause. So, but then you use your clinical wisdom and assess for if there is any chance for a secondary cause, and assess target organ damages. These are the main causes for secondary hypertension. Again, the time will not permit me to go to each one of them. I will not again spend much time on the pathophysiology and the hemodynamics of hypertension, because this is the pathophysiology remains same, except to say that you have big trouble when you have a persistently high blood pressure. Just look at the ALHAD data. ALHAD was one of the largest hypertension trials, 49,000 patients. And look at that, a 44. If you have a resistant hypertension, your outcomes looks abominably, pretty bad. Now, excess stroke, all-cause mortality, heart failure, ESRD, they are all multiple times higher rather than in a person with a controlled hypertensive patient. So how will you tackle that? How will you manage them? So basically, rule out pseudo-resistance, see the medication is adhered to, and optimize these 3 drugs: a RAS blocker, a calcium channel blocker, and a diuretic. There was a little bit of confusion. Of course, I don't need to stress about, Manikantan talked to you about 12-15 minutes about the importance of lifestyle modification, and I don't think I should again rub it in. But then importance of, I will just concentrate on, he has dealt you detail on the diet and the exercise. Just look at on the last column, the amount of blood pressure reduction that you could achieve even without any drugs. So that is substantial. And this is again something just you wanted to concentrate on. Look at the proportion of blood pressure reduction. A reduction of 20 millimeters systolic blood pressure. A reduction of nearly 10 millimeters of diastolic blood pressure reduction with a optimal salt reduction. So, I mean, this again tells you about the very many mechanisms of salt reduction and the improvement. So, salt reduction amongst the all lifestyle modification is something which you have to emphasize on that. So, I mean, step 2, the older algorithms tells you that maybe you can change if the patient is on 3 drugs and the diuretic that you are using is a thiazide diuretic, you may change to non-thiazide diuretic, because now the diuretic of choice, this is an older data. Now you can look at the MR-FIT, ALHAD, Accomplish, all these are older data. There was a time when we believed that chlorthalidone may be better than hydrochlorothiazide, and there were meta-analyses, some of these head-to-head comparison of smaller data, which also showed that indapamide and chlorthalidone may be better than, because now hydrochlorothiazide is a short-acting drug. But this one, published in late December 2022, told us that there may not be much difference between chlorthalidone and hydrochlorothiazide, using it judiciously, titrating it properly. And so that is the status of your diuretic in hypertension. There may not be much of a difference between chlorthalidone and hydrochlorothiazide, except maybe in some subgroup, those who had an established myocardial infarction or those who had a heart failure patient with hypertension. There, in that subsets, but subset analysis is something which you cannot just harp on. So which is the most preferred fourth drug after your ACE, ARB, CCB and diuretic? And there comes the importance of aldosterone antagonist. A forgotten drug, a drug that has been with you for a long time, which we have been hesitant to prescribe. And we have now important data coming on the importance of spironolactone as an important drug in resistant hypertension. And this is the best choice before possibly you introduce a beta blocker even, unless there is a compelling indication for beta blocker. So as the fourth drug, definitely you should be using spironolactone antagonist, and we have enough and more data right from the ECCON to the Pathway 2 trials, which tells that aldosterone antagonists, both spironolactone and eplerenone is a costlier version of spironolactone, they will work. Also, the potassium retaining drug diuretic amiloride, which is rather difficult to get it, but that also is an important agent that we can use. Is there any newer drugs in the anvil for resistant hypertension? Unfortunately, not much. We have increasing trials are being done using ARNI, angiotensin receptor neprilyzing inhibitor, which is one of the foundational drug in heart failure. So more trials are being done, and we don't have a guideline recommendation, but we have increasing. If you have its off-label indication, you can definitely try ARNI if you have a situation, if patients are not responding even to spironolactone, change your ACE ARB to ARNI. These are some of the drugs which are again in the air. We don't have any FDA approval on any of these drugs, but these are the groups of drugs. Aldosterone synthase inhibitors. Now, earlier we were using MRAs, receptor antagonist. Now we have another groups of drug of synthase inhibitor, and also an injectable forms of RNA-based therapies. And celibizaran is being used, tried. We will have to see, wait and see. Renal denervation, it surprised us earlier with the Simplicity series of trial years ago. But then when the Simplicity third came, the sham control trial came, people lost faith in that. But it is coming back with a vengeance. We have increasing amounts of data. FDA has approved RDN for the treatment of resistant hypertension. This was one of the newer data with newer modes of ablations technique. People are finding it substantially useful. Now, again, the long-term data of this radiant hypertension trial will possibly cement its place in the treatment of resistant hypertension. This is again another not new, but this has been there maybe for the last nearly 10 years. Nothing much has happened to it. But again, there are trials going on a pacemaker-like device producing baroreceptor reflex activation, and people have found that it may be useful in resistant hypertension. So, ladies and gentlemen, resistant hypertension is a challenging clinical problem. It's important to differentiate from pseudo-resistance, and you have to, in a small proportion of cases, it could be a secondary hypertension, so you have to rule it out. Establish is it true resistant by doing a ABPM. look at the comorbidities of the patient. A stepwise approach which I have just described will possibly mitigate the elevated blood pressure in a sizable amount of patients, and we have devices available which can be also used, especially RDN. I will not be doing a service without just telling you there is a massive gap in the management of hypertension in India. Thank you very much.
Thank you, sir, for that excellent overview. Hypertension is a problem that we always face. I think the most important thing is to recognize true versus pseudo resistance. In the nephrology practice, we have seen many patients who are receiving minoxidil for resistant hypertension. Do you have any experience or opinion on?
I think nephrologist will be the best guy to talk about minoxidil. I don't have too much of an experience, except for the fact that there is a recommendation saying that you better also add a beta blocker when you are using a minoxidil. Jairaj, you are the best person to talk about minoxidil.
Actually, I congratulate Mohan for the brief review. And one point I would like to make out is that, do you consider primary hypertension only as secondary, resistant hypertension?
You exclude secondary causes because most of them are reversible. That's all.
Yeah. The thing is that many causes are not reversible, especially when you consider CKD. It is not reversible, but it is very difficult to treat because many a time we require 3, 4, 5 drugs to maintain a semblance of control. Even then, it will not come to the proper, say, 130/80 or something like that. And as far as minoxidil is concerned, we had been trying minoxidil as the last drug, 7th drug or something like that. But generally, it's not easy to get. Number 2, the effect probably is not due to, if you properly dose the other drugs, probably you don't require minoxidil at all.
The patient is having a BP of less than 140/80 and still he's taking 4 medications for hypertension. Do we still consider them?
That is where your guidelines come. So now if you insist on 130/80, I will appreciate that. And if you go further, then I may down titrate. But I will try to reach it to, not to the 120/80, but at least 130/80 will be my goal.
The problem was actually the sprint trial, the recording of the blood pressure is not really practical. That's exactly what happened. Probably those patients who are having 120/80 or even less, probably the normal.
That's why we compromise on 130/80. We don't want sprint for everyone.
Sir, one more question to Jairaj, sir. How much, in our part of the world, there is a lot of compulsive water drinking. How much does this compulsive intake of water by patients, thinking that it is healthy, contribute to this controlled hypertension?
I would say that it will make kidney work more. So that especially a kidney which is not properly working, it is actually asking it too much. The thing will be, basically the body will control. If you control salt, if you control the other clinical non-pharmacological methods, well, then depending upon the requirement, if the patient is working outside, probably he will drink more. But there is absolutely no way you have to recommend that you have to drink 3 liters of water in the morning.
Thank you, sir.